Alison. I'm the lead for learning disabilities and, I'll start again because you've started recording. I'm Alison. I'm the lead for learning disabilities and autism at Leeds Teaching Hospitals. I've got some slides to share with you just now, and this is when I cross my fingers and my toes, and I hope that when it says it's sharing, it's actually sharing. Can I get a shout out, please? Can you see my slides?
Yes. Yep.
Yes. Fabulous. And they're even in slide mode. Now they just have to move. So I'm Alison. I'm the lead for learning disabilities and autism at Leeds Teaching Hospitals, as I just said. I'm coming today, I guess, to talk a little bit about barriers to healthcare. I'm going to give you some examples of things that we're doing in Leeds. Some of these, obviously, I'm aware that this is a regional meeting, so some of the things I'm going to talk about will cut across different regions. Some of them are more specific to Leeds, but still potentially worth you hearing about and thinking about. So there we go. So, I went to move the slide on and it didn't move. Clicking the slide and it's still not moving. There we go. So why are we here? So we're here because actually it's really difficult for people to access healthcare services, and we hear this time and time again. There are so many barriers for people accessing healthcare in general, particularly I would feel hospital services. So this is a study that came out last year that showed us, the vast majority of people find it really difficult. This was looking, I think, more so at GPs, but over half of people are even struggling with the GP waiting room environment. So if that's tricky, add in ambulances, add in all of the chaos that we have in our emergency departments, and you can start to see why things are really difficult. A lot of the systems that are in place across the NHS are not very friendly for neurodivergent people or people who are digitally excluded. There's a lot of, I think, historic systems which we expect people to fit into rather than trying to make our systems always fit to people. So you can see why it's so difficult. I want to move my slide again. It's not moving. There we go. So what happens when it's hard for people to access services? We know that people come late, which we know that people have got untreated physical and mental health conditions. So, for example, people might put off coming with something that's fairly minor. So my mother-in-law is an absolute classic example of this. She'll say, I don't want to go to the doctors. I'm not going to bother the doctors when she's got a little infection. And we're going, come on, you need to go to the doctors now. And then by the time she does go, she's got a whopping great infection. She needs IV antibiotics and a hospital admission. Whereas if she'd been able to access healthcare sooner, she would have probably just managed with some tablets. So it's that thing about getting in early to get the treatment that you need before things escalate. We see really poor compliance with sort of screening programs. So screening that people do find really hard to access, so things like smear tests, or even just coming in when they do have a specialist referral. Autistic people and people with learning disabilities are less likely to come for a variety of reasons, either because it's hard for them to come or because they're supported by people that don't bring them, and they're not brought to their appointment. We sometimes see people in the wrong place at the wrong time, and I know we say there's always there's not a wrong door, but it's sometimes wrong for that person. So something that could be seen in the community or a sort of a lower level service, we still sometimes people just default to come into the emergency department if they're not really sure where to go. I always remember talking to one of my champions with a learning disability, and she was complaining about how long she'd had to wait in the emergency department. We chatted a bit about why she was here, and it was because she'd got some cotton wool stuck in her ear. Well, you will wait a long time in the emergency department if you've got cotton wool stuck in your ear, because there are going to be people who are really unwell. So we know that when people don't know where to go, they sometimes just come to ED in an acute state or just by default. We do see sometimes that people have got worse health outcomes because of initiatives. Can you hear
Would
me?
you listen out for the door? Because I might have a parcel being delivered.
No, just ask people to go on mute if they're listening. Thanks.
That's all right. We see worse health outcomes for our people. So, for example, a lot of services use this thing called patient next move, or they sometimes call it PIFU, patient initiated follow-up. So with that, they send you a bit of a vague letter going, you were fine in clinic today, come back to us if you need to, or come back to us if your symptoms get worse. And that really does not work for our patients with learning disabilities and our autistic patients, because it's often really not specific. There's no criteria about what does a worse symptom mean. When should things get better? What does that look like? So there are systems like that that we know don't work for people. We know that when people can't access healthcare, they will look at other ways to try to make themselves feel better. And that's often self-medication. So people who use alcohol, people who use non-prescription drugs to try to just get through the days for things which potentially would be treated by good quality healthcare if only it were accessible. We know that people have poor experiences that then make it doubly hard to come back. And we've talked a lot about this at the minute with phlebotomy. So if people have got issues having their blood taken, and I'm sorry, I can't see people's faces if this is triggering for anybody, but if you've really struggled having a needle, we've then got all of that unpicking to do to help you to have it the next time, because I think that poor experience that hasn't taken into account, for example, somebody's sensory needs or their processing time or whatever it might be, that then makes it so much harder in the long run if we're working through that layer of a bad experience. So, it's time. There we go. So for learning disability and autism, I guess what I'm saying is that nationally the picture is really bleak. We know that health inequality is widening actually since the pandemic. We know that people are having this really difficult time. There's a lot of talk about premature mortality. A lot of talk still, unfortunately, about diagnostic overshadowing, which is where they see people working in healthcare might see the learning disability or the autism and they might miss what is the physical health condition. You know, if somebody's lying flat in their bed, they might think that they're always like that and that's part of their learning disability, whereas actually normally the person's up and about and active. So there's still talk about nationally diagnostic overshadowing, a lot of talk about health inequality, but locally I would like to think that it feels a little bit different. And certainly I can only speak for Leeds, but I feel like we've got a pretty strong view of where we are. That doesn't mean that we've got it right, but it means that I think we know our data is strong enough that we know where the issues are, and we've got good relationships with sort of since I came into post in 2018, we've grown to a team of 10. And that's been through temporary money or pilots or showing the need and really evidencing what it is that we need for people with learning disabilities and autistic people to come into hospital. And now we've got that permanent structure in place. So last year we had over 5,000 referrals into our service. And if you compare that, so when I first started at one point, I had a caseload of 11. And now we're having 5,000 referrals a year. So that just really shows you what things look like in the hospital now. Our pathways are getting better, and so is our data. So here's us. This isn't quite the current team, but this is basically what the team looked like. So for us in Leeds, we're a hospital-based service. We're different to some other services because we work across the whole of the lifespan. So that means from as soon as somebody is born, for example, babies born with Down syndrome, our team can be involved from day one, all the way through people's lives. We're a little bit different from other services as well because it's not all learning disability nurses, there's a mixture. So we've got general nursing, physiotherapy, and I'm a speech and language therapist. And the three things that we try to focus on, because that's what feels right for the people that we support, is the clinical service, the improvement of quality, and the education of our staff. And I'll talk to you about a little bit about what that looks like for some of those areas. So the support that we tend to offer to people might look like this. So we've got health passports, which are absolutely top of my list for people to really, if you've got one take home, it's please push health passports. We used to have, so health passports, I don't know if you can see them, there's just the front sheets of them that are there at the bottom. We've got one that's for learning disability and one for autistic people. We used to have them on paper. If I'm honest, I think that's probably one of the good things to come out of the pandemic, is that we don't really encourage paper passports anymore, because if you've got paper, it's probably in your bag and it's only the people at your bedside that can see it. Whereas if it's on the system, people can see it before they come to your bedside, and people who are involved in other aspects of your care, so things like bed managers, they would never come to your bedside, but they would see it if it's saved online. So for us in Leeds, you can send them in. I know some other areas are doing that as well, rather than being reliant on paper or things that are handheld. We do a lot around easy read information. We know that a lot of hospital information is exceptionally complex. And I have to say, whenever you get a letter, one of those centrally generated letters that's really long, that they're hard for most people to understand, not just people with a learning disability and autistic people. So we focus where we can on delivering easy read information. Our leaflets in Leeds all look like these ones in the middle at the bottom. They're all done with a proper governance process where people with living experience of learning disability and autism will help us to proofread the information, so they should be a fit for as many people as possible. Never going to work for everybody, but hopefully they'll help some people. I think we've got about 135 leaflets that are live now about various different aspects of care. The team will offer specialist advice, so that would be if we've got people coming into the hospital, our team will review them within 2 days and will support with specialist advice where we need to. I think a lot of people might have heard about these emergency care bags, and these are not just used in Leeds, they're used in some other areas across the patch too. So if you come to the emergency department here and you've got a learning disability or you're autistic, there'll either be a sign up or you can just ask for a care bag. They're pretty good. We're really proud of these. I think 25 hospitals nationally have got them now. We've given out 2,000 in Leeds already. But in the bags, there's information about what's happening, information about what's going on in the ED. We know that it's very noisy, it's very bright, it's pretty antisocial environment. So we've got some really decent ear defenders, an eye mask, fidget bits, things to do while you're waiting, all included in that bag, as well as a feedback form to help us to know what else we can do next. So that's something that works really well from us. I know some areas it's different, and you have like a red hospital bag that you bring in with you. We haven't done that because maybe partly because we're a major trauma centre, I suppose, but people often don't plan to bring a bag with them. They often just pitch up in a crisis with nothing. So for them, that's why this emergency department care bag is really important. We offer training, like I've said, to our staff across the workforce. And there's also, if you haven't heard of these Access Able guides, they're pretty good. They're very detailed. They give you like a really, even down to, if you're going to this department, click here. This is your route through to the department. Click here. The lift has got a button at this height. The shelf for your colostomy bag is at this height. So there's all sorts of information that's there on those Access Able guides, and particularly some of our autistic patients find them super helpful.
Alison,
yeah,
someone's asked in the chat if you know if those are available in Bradford. Or if we've got any Bradford colleagues on the call, maybe answer that question if you can't.
I think that Bradford have the red bags where the idea with that is that you prep a bag to take with you. If there is a Bradford colleague that can answer. I'm sure Bradford have got red bags, not care bags. Places tend to have one or the other scheme that's running.
Thank you. Victoria's put a hand up. She might be Bradford based.
Yeah, can you hear me?
Yeah.
Yeah, I'm from Bradford. We do have the red bags available, and Waddy Loves, they're good to link in with to get them red bags if you're needing to get hold of them.
Thank you. Cheers, Alison, as you were.
A couple of other bits that I've put on this page, just the kinds of things that we offer in terms of support. So our VR headset, this is something that is really popular. So VR can be used in different ways. So some people use it like for a virtual tour of a department, things like that. We use our headsets for distraction during procedures. So there was one man, I was with him yesterday actually, who he used to come in for an anaesthetic every time he needed his catheter changing, but he doesn't need that anymore. He doesn't need to come and stay in the hospital. He just uses the headset. So whilst he's having his catheter changed, he's watching an underwater scene. He can't see what's happening, which the visual actually was making him really anxious, giving him procedural anxiety. But with that visual from the headset instead, it's great for him, and he's in and out in half an hour or even less. We keep trying to set a record every time he comes in. So the headsets are great. Also great, I mentioned phlebotomy earlier, people who are really just don't want to see a needle. The headsets can work, and that, you know what, they really do. So we've got there was an autistic boy who was able to, he's hypersensitive to touch, but with the cream that they put on and using the headset, they asked him afterwards how many times did the needle go into his arm, and he genuinely could not say, because he did not even feel it, his blood being taken. So these are great for so many people. I guess the other thing to say is people have got their own supports like this, and a lot of people have their own headsets. Anything that you can think of that will support your hospital stay, and I know colleagues across the patch would say the same. Bring it with you, bring your own things, bring what works for you, especially if it's something that's planned. If you know you're coming into hospital, we often get asked, can we not have care bags in every department? And I'm like, well, no, because they're expensive, but also because if you're coming into a department in a planned way, you know you're coming and you can prep to bring your own things that might help you, that are more bespoke to you. There's a few of the things that we would offer as a team. So this is kind of over the last year, some of the things that we have done that we're super proud of. So if somebody comes into hospital, they'll have an initial assessment, and they'll have identified reasonable adjustments. And what we found that we were doing with our notes, because we're always open to learning, what we found that we were doing with our notes was kind of almost copying some of what the other clinicians were writing. And because we were so keen to get in everything, we didn't always focus on what is this person's need as a person who's autistic or a person with a learning disability. And so we revised that assessment, and we took out some of the other stuff and kept it really specific to the reasonable adjustments, and our clinicians really like it. Just that increased focus is helpful for them. We've got an ongoing review from our team if people need it. A lot of people manage without our support, but the wards can ring us at any time and say, do you know what, this person's actually, they're struggling to sit still for the chemo, and what else can we do? What can we put in place to help to make their life easier while they're with us? Sometimes we can offer advice over the phone if we know we've got people coming in, or sometimes we'll go out to see the person wherever they might be. Anybody can contact us for support. If you've got somebody that's waiting to come in as an outpatient, or if you've got somebody as an inpatient, or somebody that you've discharged that you're worrying about and you're wanting to make sure that the discharge referrals are in place, they can get in touch with us. For our outpatients, we've recently started some of our desensitisation work. We do, like many hospitals, really try to plan ahead for patients. So if you're coming in for an anaesthetic for one thing, what else do you need that we can do at the same time? And I was saying that, like, one of my career highlights was when we managed to sort out a man's teeth and his testicles and his toenails in a single anaesthetic. And I thought, wow, that's it. That's probably as much as we're going to achieve. And then we did some bloods. So I was, yeah, but we will always, if we can, try to make things easier, reduce attendance, reduce the amount of anaesthetic that somebody needs. We can't go to all our outpatients. I know people often wish that we could. We'll go by exception for our outpatients, but because we've got more than 10,000 a year, we just can't get to everybody. We encourage our staff to be creative where we can do. So this lady here who's sitting in the car, she's having an eye test in the car because she couldn't manage to come into the building, and it worked really well, and it worked well for her, and yeah, it was great. It meant that they got the information they needed.
Alison,
So
we've had another couple in the chat, if that's all right.
yeah,
The first one is if Calderdale have the bags.
Calderdale have the care bags in the emergency department, yes.
Brilliant. And the other one was how are reasonable adjustments shared across the departments, and is there any sharing across trusts? We can save that one to the end if it's going to be
I mean, wouldn't it be lovely if all of our computer systems talk to each other? A lot of the sharing that happens between hospitals happens because we've got a strong network of acute liaison clinicians. So, for example, with a regional centre, we'll take a lot of people from Harrogate, from Bradford, from all over really. But we know those acute liaison clinicians in those other trusts. I would always say to expect that things haven't been shared, just because I can't guarantee I don't know where the person's coming from that's asked the question. But if you're going to a different hospital, it's worth either contacting the liaison person in your local hospital and saying, I don't know, send my details over to Leeds, or it's worth contacting us directly. And we'll try and do the same. So if we get somebody that's coming in who, I don't know, we've got a Wakefield patient who survived with us, and we don't have a whole lot of information for them, we will ask them and try to do some, discussion around reasonable adjustments if we can. But we'll probably also contact the local service and say, Bob's here, what do you know about Bob, and has anything worked in your hospital to help him? So we'll try and do it informally, but it's not always automatically shared. There are some common record keeping systems. So if you've sent a health passport to us, for example, and we've uploaded it, Mid Yorks, which is like Pinderfields, will be able to see it on their system, but that doesn't necessarily work right the way around the region. There's some talk about a national reasonable adjustments flag, and I don't know if anybody's come to talk to this meeting about that. There is a national project where people can have their reasonable adjustments added, often through primary care, through your GP, onto their notes. People are sort of saying that that's going to be the answer to information sharing, but I'm a bit skeptical that it's not the answer yet, because we can't actually see it. So you'll have given all of your adjustments to the GP, and if you do that, still, please do check, and can the hospital see this? Because at the moment that flag's not rolled out enough for it to be shared from place to place. Any more questions before
No,
I
you're
go
safe.
on?
Go on. Thank you.
So quality improvement. So these are some of our sort of the initiatives that we've put into place, and they all come through from understanding where things aren't going well, basically, and that comes from a range of different information for us. But I've talked about the VR support for unpaid carers. That's really big for us at the moment. We're doing work around paid and unpaid carers, trying to make sure that when people are in hospital that they get the right level of support. So we've had previously, and if I could see you, I bet you'd be rolling your eyes. But for example, somebody comes into hospital and I'll go and see them, and I can see they've got really poor oral hygiene. And I'll say, have you brushed your teeth? And they'll say no. And I'll say, oh, I've got a carer sitting with you. And I'll ask the carer, have you brushed their teeth? And they'll go, oh no, because we're in hospital, we didn't know if we could brush their teeth. Should the nurses do that? And the nurses I'll go to the nurses and they'll go, well, we haven't brushed their teeth because they've got a carer with them. What's the carer doing? And I think sometimes we haven't always got that communication right about roles and responsibilities. And that's something that we're really keen to make sure that we do get that right moving forwards. And I know that that's not unique to Leeds. I think that happens in other places as well, that the roles of what paid carers are doing when they're here with people is something that we're still trying to iron out a bit. But support for unpaid carers, I know we've had families say, I can't leave them. I don't feel able to leave them. So then they'll end up staying with them, and we can put in support. We do often put in a camp bed or, various initiatives to support our unpaid carers, but we also don't want them burning out. So for that situation, I guess it's a conversation around what can we do to help you to feel confident to leave? Is there anything that can make this feel better? What are you doing that we can do instead? Or what can we learn from you? Really building that relationship so that relatives are seen as one of the team, because they haven't always been in the past. Accessible information I've mentioned already. Elective recovery planning. This looks different everywhere in terms of quality improvement. And some places there's a system. So perhaps in some of the smaller hospitals, there are systems where if you've got a learning disability, if you're autistic, you might be seen within a certain time frame. With us, we're trying to take a more person-centred approach to that when we're looking at planning elective surgery for people. Obviously, like everywhere, we're auditing what we're doing, we're benchmarking what we're doing to compare our own performance year to year, but also to compare against what other big acute hospitals are doing, to see if there's any learning that we can be doing with them. I've talked about electronic passports and I've talked about care bags. Training and education is a biggie, and I know you'll have had some discussion about this in other meetings. For us in Leeds, the number of staff who we're training continues to grow, and that's certainly something that I've been keen to work on, and we're lucky that we've got a clinical educator now, Cherie, who's in the bottom of your screen, who she's permanently into post with us. It is an exciting time for training, not just in acute hospitals, but across other health and care provisions as well. So the Oliver McGowan training, the final code of practice, I mean, they've been telling us it's coming. I do hope that it's coming really soon, that final code of practice, but there's lots of conversations even before that across the whole of West Yorkshire, thinking about how we can get ready to deliver the Oliver McGowan training, or how we can get ready to deliver, what other training are we delivering in the meantime. So for us in Leeds, we've got co-trainers who, with the way the screenshots work, Philip's really tiny in the corner, but we've got trainers with living experience that are now pretty much recruited onto our bank staff so that they can continue to deliver training. They're there ready for whatever that training is going to look like moving forward. And in the meantime, they're delivering bespoke sessions to lots of our different staff groups. So the way that we do that is either if we've got really high frequency areas, so a lot of our patients might sit, for example, in respiratory care, that we deliver training into respiratory, or people that are developing their own pathway, so like that lovely eye clinic that I talked about, we did lots of work training and upskilling with them. But then also we do, if we have a phone call going, my relative came to such and such a department and actually I don't think the staff had the right skills to look after them, we can go in to sort of support and turn things around. So learning over the past year, we've got all of these different ways that we learn from people, and I would encourage people to use things like the PALS system if they need to in whatever hospital you're in, because it's from things like PALS that you're learning and your evidence comes. So our PALS and knock complaints, we pick up the day that they come in. We have an audit that we do every year that looks at really kind of functional stuff. So actually, of this snapshot of people in your department today, how many of them have a health passport? How many of them, do people know what reasonable adjustments are? We'll talk to, we'll get feedback from patients asking, did the staff talk to you, or did they just talk to the person that was with you? Do you understand your plan? Do you know what's happening next? Really to try and make sure that the aspects of care are covered off. Talked a little bit about benchmarking. Each hospital has their own incident record keeping system. For us, it's Datix. we are lucky that we have got a field on data, so we know every incident relating to a person with a learning disability or an autistic person comes to us in real time. And again, we're picking those things up immediately if there's any incidents that are coming through. The leader programme, I suppose you've had the talk from Lisa, haven't you? The leader programme is changing a little bit with the way that the ICBs have changed, but we've got a meeting now where we look at anybody that's had a focused review across the region to think about what learning we can take there from each other and what we can do to move forwards. So for us, this is what we're doing in this year. So we started when I say year, our years run like April to April, well, in terms of reporting. So for 2024 to 2025, so we started with Autism Acceptance Month. We've got an amazing Lego sculpture that is one of our patients has donated to us as a sort of recognition of what autistic people can do. We use some of the poetry that this group have put together and showcase that all across our social media. So all sorts of things for that. We had a staff champion conference in Learning Disability Week. We've got posters that have gone out for all our wards and departments, really helping them to think holistically about people and the support that they need. We're looking again at our pathways. We're just rewriting our strategy at the moment. So anybody that's in Leeds that I know is about to get an email saying, will you come to one of my consultation meetings? So a little heads up for that. We've had a new structure put into place in the hospital. So we've got a new chief nurse that's here now and some tier of deputies. They're each looking at things a little bit differently to how things have been looked at before. But they're changing the way that our governance works here in the trust. The 3 C's work, so that's all about kind of compassion, coordination, how we care for people, that approach. And part of what we've done for that is the Hello, My Name Is campaign that we relaunched this year. So we've done some work for that. We've got a link teaching people how to say hello, my name is using Rackathon. I'm really just thinking about what our core business is, so sort of reducing health inequality, improving the patient experience, but also with that is getting it right first time, and that actually means saving money. So sometimes we spend a little bit more money, but we save it in the long run, and actually it's so much better for the person across the board, helping things to be successful either on the first attempt or as close to the first attempt as we can. And that's it for me. But I'm hoping there's some more questions that are coming through. Have a look in the chat.
Thanks so much, Alison. That's really informative. Loads of really good stuff going on there. And like for questions and stuff, like there's so much learning for other trusts that I'm you know, everyone's not doing all that stuff. And it's so easy to share. I think maybe, you know, I'll speak to our programme as well and be like, can we take this to a steering group? Look what's going on elsewhere. There's no reason we can't replicate it in every area. Has anyone got any thoughts, questions? Rebecca Thomas put, can we refer service users to you, and if so, how?
Yes, absolutely. Are we going to keep the recording running or stop
yes, sorry,
it?
good spot.
That's all right.
Stop recording.
Just in case anybody's got anything personal and then referral. So yes, you can. So for us in the hospital, we'll take referrals by any which way we can take them. So